Welcome to Safe Delivery Module Kwanda, Cases 1-18. This module will cover key questions and correct answers to ensure safe delivery practices. Let's begin with cases 1 through 4. What can be done to reduce the risk of postpartum hemorrhage? Active management of the third stage of labor more than halves the risk of postpartum hemorrhage. The effect of giving uterotonic drugs immediately after delivery to prevent excessive bleeding is scientifically documented. After the delivery of the newborn, what steps will you take to prevent postpartum hemorrhage? If available, give an oxytocin injection within 1 minute of birth. Otherwise, give Misoprostol orally. Allow the placenta to deliver physiologically or deliver it by gentle, controlled cord traction. A 23-year-old woman has just delivered twins, and suddenly heavy bleeding occurs. What are the first steps? Call for help and perform a rapid assessment and emergency management. Give uterotonic drugs and perform bimanual compression if bleeding is not controlled quickly. Perform continuous uterus massage. While performing bimanual compression, what should you ask your assistant to do? Position the head down if not already done. Insert 2 IV lines and give up to 3 liters of IV fluids rapidly. Give drugs to help the uterus contract. An 18-year-old woman delivered a boy. The placenta is intact, yet bleeding persists despite uterine massage. What are the possible causes? A tear in the cervix and/or a perineal tear, a vaginal tear or placental tissue remaining in the uterus. A 27-year-old woman delivered 20 minutes ago. The placenta has not delivered after 3 attempts. She is bleeding heavily and shows signs of shock. What are your initial actions? Call for help and assess vital signs every 15 minutes. Insert 2 IV lines and a urine catheter. Give at least 2 liters of IV fluids rapidly. Keep her on nothing by mouth. Now let's move on to cases 5 through 7. For a 20-year-old primigravida at 34 weeks, what is important at every antenatal care visit? Measure blood pressure and ask about previous obstetric history. If her blood pressure is 165 over 90 millimeters of mercury, what should you do? Assess blood pressure again after 10 minutes in a reclined position. Assess urine for protein. Assess the fetal heart rate. Ask for signs of severe preeclampsia. Which are signs of severe preeclampsia? Systolic blood pressure at or above 160 millimeters of mercury, right upper quadrant, abdominal pain and visual disturbances, decreased urine production, and persistent headache. Which statements regarding severe preeclampsia are true? It usually progresses and can become life-threatening. Systolic blood pressure at or above 160 millimeters of mercury is the most important parameter to control. Delivery is the final treatment, but the condition can worsen in the postpartum period. If the woman has an initial seizure, what actions should you take? Call for help and protect her from injury. Treat blood pressure at or above 160 millimeters of mercury systolic with intravenous antihypertensives. Give magnesium sulfate 4 grams intravenously very slowly. A 25-year-old term pregnant woman has a cervix dilated to 5 centimeters at 9 a.m. What should you do? Admit her, as she is in the active phase of the first stage of labor, and start the labor care guide. Allow her to walk around. Assess the fetal heart rate every 30 minutes. Perform the next vaginal exam after 4 hours. After 4 hours, the cervix is 7 centimeters, membranes intact, with strong contractions and head 1/5 palpable. What do you do? Recognize prolonged labor, dilatation to the right of the alert line, perform artificial rupture of membranes, get her up and walking, ask her to urinate. After rupturing the membranes with a fetal heart rate of 130 beats per minute, what are your next steps? Do the next vaginal exam after 1 to 2 hours. Assess fetal heart rate every 15 minutes. Encourage her to stand and walk. Allow pushing after emptying her bladder. Assess the fetal heart rate after every contraction and at least every 5 minutes. If after 1 hour of pushing there is no delivery and the fetal heart rate is 80 beats per minute for 5 minutes with maternal exhaustion. Indications for vacuum delivery include prolonged pushing, maternal exhaustion, and a fetal heart rate below 100 beats per minute for 5 minutes. Note that vacuum delivery is contraindicated at a gestational age below 36 weeks. A 14-year-old girl presents with lower abdominal pain, shivering, and appears ill. What should you do? Ask if she was pregnant and had an illegal abortion. Measure blood pressure, pulse, respiratory rate, and temperature. Ask about her last menstruation and perform a urine pregnancy test. Talk to her alone and assure confidentiality. If she is hypertensive, tachycardic, febrile with a positive pregnancy test and a history of illegal abortion, call for help. Assess vital signs every 15 minutes. Insert 2 IV lines. Give at least 2 liters of IV fluids rapidly. Insert a urine catheter. Keep her on nothing by mouth. After fluid resuscitation and suspecting septic abortion, perform a vaginal exam and abdominal palpation. Prepare for rapid evacuation of the uterus. Finally, let's cover cases 7 through 9. If she has pain over the pubic bone, a tender uterus, minor bleeding and foul-smelling discharge, what do you do? Treat a septic abortion requiring surgical intervention, such as manual vacuum aspiration. Recognize that septic abortion can be fatal if not treated immediately. If no sterile gloves are available, what is your approach? Only proceed using sterile gloves. Disinfect your hands with alcohol or allow them to air dry after washing. Key post-abortion care points. Manual aspiration is safe up to 12 weeks. Continue intravenous antibiotics for at least 48 hours after the woman is fever-free. Septic abortion may increase the risk of infertility if not managed promptly. A woman at term with spontaneous rupture of membranes at noon and no contractions presents. What do? Perform a vaginal exam to assess cervical dilatation. Measure vital signs. If stable, send her out to walk and have her return when contractions begin. If none, have her return the next morning. Expect that contractions are likely to start spontaneously. At 5 p.m., when labor pain and regular contractions begin, what are your actions? Start the labor care guide for the active first stage of labor. Check her antenatal card for HIV status and tetanus vaccination. Reassure her and encourage accompaniment by her husband or relative. After delivery the next day with a 900 milliliter postpartum hemorrhage, a repaired perineal tear, and a newborn not breastfeeding well, what are the infection risk factors? Postpartum hemorrhage, perineal tear, 18 hours since rupture of membranes, a newborn not breastfeeding. If the mother returns the next day with signs of shock, what do? Give broad-spectrum intravenous antibiotics. If in a malaria area, add malaria treatment per protocol. Ensure her airway is free. Provide oxygen if available, and call for help as she has septic shock. Insert 2 IV lines. Give at least 2 liters of crystalloids rapidly. Insert a urine catheter. After stabilization, perform abdominal palpation, a vaginal exam, and assess the perineal wound. Check for rash or erythema. If urine output is less than 50 milliliters per hour, give more IV fluids. Monitor vital signs hourly until stable. If no improvement after 24 hours of intravenous antibiotics, suspect retained products and prepare for cautious manual vacuum aspiration. Consider referral to a higher level facility. During assessment, a newborn is not crying, is floppy with blue lips. What should you do? Clamp and cut the umbilical cord. Stimulate the newborn by drying and rubbing its back with a dry cloth. Assess the newborn's heart rate. Start inflation breaths with a ventilation bag. Call for help. Ensure that by 1 minute of age, the newborn is breathing or is ventilated. All right, let's dive into cases 10 through 12. A newborn needing resuscitation. What are the important actions for ventilation breaths? Position the head in a sniffing position. Deliver ventilation breaths at approximately 40 breaths per minute. Ensure the chest moves with every breath. Assess the newborn every minute during ventilation. If the baby is not crying or breathing, is blue, and the heart rate is less than 100, what do? Continue resuscitation with 40 ventilation breaths per minute. Start chest compressions. Ensure the chest rises with every ventilation breath. If the chest is not rising during ventilation, what should you do? Try to lift the newborn's jaw forward, also known as a jaw thrust. Try a different mask. Reposition the head. Ensure the chest rises with each breath. Once the newborn is crying with good color and tone, what are your next steps? Place the newborn with the mother for skin-to-skin contact. Start early breastfeeding a 25-year-old at 32 weeks with preterm premature rupture of membranes presence. What do? Give the mother 12 milligrams of betamethasone intramuscularly twice, 24 hours apart, or 6 milligrams of dexamethasone 4 times, 12 hours apart. Measure the hemoglobin level if not done already. Give the mother ampicillin 2 grams intravenously every 6 hours to prevent infection. After 20 hours, there is a spontaneous delivery of a 2,000-gram newborn with a heart rate of 180 and a respiratory rate greater than 60. What should you do? Give the newborn ampicillin 50 milligrams per kilogram intravenously or intramuscularly twice daily for at least 2 days. Give the newborn gentamicin 5 milligrams per kilogram intravenously or intramuscularly once daily for at least 2 days. Initiate early feeding. Keep the newborn warm by skin-to-skin contact with the mother. A 38-year-old woman in prolonged labor delivers a newborn that was initially pale, limp and gasping, but improves after resuscitation with an APGAR score of 10 at 5 minutes. What do you do now? Check breathing and color every 5 minutes. Give 1 milligram of vitamin K intramuscularly and apply eye ointment. Start breastfeeding within the first hour. Give the newborn to the mother. Instruct in skin-to-skin contact and advise to call if the condition changes. Ensure privacy for the mother and family. Let's move on to cases 13 through 15. A newborn is covered in thick meconium but then starts crying after suction and stimulation. How do you examine and monitor the newborn afterwards? Use the ABCDE approach: airway, breathing, circulation, disability, exposure. A 21-year-old primigravida with spontaneous labor, no complications, and no thick meconium delivers a newborn. At 5 minutes, the APGAR score is 10 with normal respiration. What should you do? Check breathing and color every 5 minutes. Give 1 milligram of vitamin K intramuscularly and apply eye ointment. Start breastfeeding within the first hour. Give the newborn to the mother. Instruct in skin-to-skin contact and advise to call if the condition changes. Ensure privacy for the mother and family. Now let's go through cases 15 to 17. A primigravida at term delivers a newborn covered in thick meconium and the newborn does not scream or breathe. What are the immediate steps? Call for help. Immediately suction the newborn's mouth and nose to clear thick meconium. If the newborn remains limp and not breathing, open the airway in a sniffing position and begin positive pressure ventilation with a bag and mask. Assess the heart rate to guide further resuscitation. A newborn discharged at 12 hours returns after 2 days with poor feeding, lethargy, tachypnea greater than 65 per minute, cyanosis and chest indrawings. What is your management? Assess other danger signs under circulation, disability and exposure. Call for help. Suspect severe infection and administer antibiotics, specifically ampicillin and gentamicin. Keep the newborn warm with skin-to-skin contact. Increase feeding frequency to every 2 hours. If unable to suck, provide expressed breast milk via cup or nasogastric tube. If the newborn has a heart rate of 190, is lethargic, pale, with capillary refill greater than 3 seconds, weigh the newborn to calculate the correct fluid bolus. Give 10 milliliters per kilogram of normal saline intravenously. Continue to suspect severe infection and administer antibiotics. If convulsions persist for more than 3 minutes, check blood sugar or assume hypoglycemia. If measurement is unavailable, give 20 milligrams per kilogram of phenobarbital. Finally, let's tackle cases 17 and 18, followed by the outro. No running water or alcohol-based hand rub is available. What do? Contact the pharmacist to obtain alcohol-based hand rub. Make your own alcohol-based hand rub based on the WHO formulation. Have someone collect water from the nearest supply so that you have water in a bucket with a pitcher and soap. 2 women are in labor simultaneously and you have alcohol-based hand rub. What steps do you take for hand hygiene before examining the next patient? Remove nail polish and ensure fingernails are no longer than 3 millimeters. Rub your hands with alcohol-based hand rub. Remove rings, watches, and bracelets. Inform the next woman and put on a fresh pair of sterile gloves. Use alcohol-based hand rub before donning new gloves. When weighing 2 newborns, perform hand hygiene. Place a clean cloth on the scale. Weigh the first newborn and return it to the mother. Disinfect the scale with antiseptic. Perform hand hygiene again. Place a new clean cloth on the scale. Weigh the second newborn and return it to the mother. Thank you for watching. For more information and training modules, please subscribe and follow.